So first we're going to do is we're going to talk about is behavioral emergencies, or what you might call psychological or psychiatric emergency. What is a behavioral emergency? Well, let's understand behavior. Behavior is the manner in which a person acts or performs in any given situation. Now, some behaviors are appropriate, some are inappropriate. A behavioral emergency, or what medicine and EMS we sometimes call a psychiatric emergency, um, Delphina, that's absolutely fine. This will be recorded, so you can pick it up anytime you want. And if you have any questions for me, you can also send that to me as well. Behavior within any given situation. Patients, there is a video on your course sites about this. If anybody's ever, heard of the reporter Geraldo Rivera, whether you love him, hate him, or indifferent to him, he's pretty well known in the field of journalism. And when he really made his big break into the field of journalism back in the early 1970s is when he broke open the report of the abysmal, deplorable conditions in which psychiatric patients were being put under a place called Willowbrook Hospital over in Staten Island. It just patients with mental disorders and some developmental disorders, as autism and other problems, were living in the just most horrid conditions. You would have them see kids and teenagers and adults all piled into the same room, either naked or basically walking around their own excrement, chained and shackled to plumbing fixtures, slop fed out of buckets. It's just crazy. And this was kept under wraps for years. The hospital itself was opened in the late 1940s. This was opened up and this was revealed in the early 70s. And the place has since been shut down. But that whole report and documentary really kind of shed light onto how poorly the mentally ill are treated in society and in the medical field as well. You know, in my own field, in EMS, we have this term for a psychiatric patient called EDP, stands for emotionally disturbed person. Politically, it sounds a lot nicer than calling the person a crazy person, but over the years, even the term EDP has brought about somewhat of a pejorative or demeaning term to it. Medically and psychologically, there is no such medical or psychological term as EDP. So how are we labeling people, or should we be labeling people? You know, what's an interesting thing is out of all those torturous treatments that we talked about just a moment ago and that you could see in one of those videos I posted up for you, one of the treatments that's actually been proven to be very effective is electroshock therapy. Now you're probably wondering, oh my God, are you serious? If you look on the left, it's actor Jack Nicholson, the movie One Flew Over the Cuckoo's Nest, and back in the early 70s. And that's where this therapy really got its bum rap from, because in the movie, they were using it as a punitive means to try to just get this guy under control. But electroconvulsive therapy has actually been shown to be somewhat effective for people suffering severe bout of depression, to the point where their bodies can't even function anymore. And its thought being is that by inducing a small seizure, it kind of, I guess for lack of a better word, reboots or resets the brain. And it's actually been pretty beneficial in the medical literature. But again, as I was saying before, these were the standards that were imposed upon psychiatric patients up until about the 1940s, when certain medications were invented and discovered that really revolutionized the treatment of the mentally ill, so much to the point where many mentally ill individuals could now be monitored and discharged home to live with their families, to live some type of function within their lives. That to some degree, that kind of rebounded the other way. And then even with outpatient therapy, there are many mentally ill individuals that should not be out on the street and not be with their families and cannot function. But that's a whole different political story and sociological story to talk about at another time. So behavioral emergencies, Patients may appear to be confused and have an altered mental status. Now, I think we've heard that term altered mental status before. Somebody's behaving oddly, abnormally. Now, the thing that I really would like you to take home and consider is the fact that there's a lot of situations that can cause a person's behavior to be altered or abnormal that are completely physical or biological in nature. Most obvious, which we talked about last week, is low blood sugar or hypoglycemia, lack of oxygen or hypoxia. You tell an asthmatic who can't breathe to calm down, it's not going to happen. Stroke or inadequate blood supply to the brain. Person may just be completely staring at you blank in the face, but able to process everything that you're saying to them, but not able to express anything outward to you. Head injuries can be a cause of bizarre behavior. As a person's recovering from a head injury, sparks are flying in the nervous system, in the central nervous system. People can be very agitated, angry, lethargic, and then boom, collapse. And also, we got to always consider the mind-altering substances like alcohol or illicit drugs, so to speak. Other things can cause behavioral differences as well. Nutritional deficiencies, thiamine deficiency, electrolyte, sodium deficiency, so many other things that we can talk about. Hypo and hyperthermia. But either way, I mean, we're not going to go into detail into every single factor. Just understand that you should always think, at least consider the possibility of a medical situation or a biological situation prior to chalking somebody up as just being mentally ill. Internal bleeding, shock, another very popular cause of change in mental status. And most people won't consider it unless they look for it. So it's way beyond the scope of what we're talking about today to go into all the different types of psychiatric illnesses there are out there. But I'd just like to talk about some of the more common ones that are out there. One of which, and probably one of the most common mental illness is anxiety. Now, anxiety covers a broad spectrum of conditions like general anxiety disorder, PTSD, panic disorder, social phobia disorder. But in any event, anxiety is a tool that your body has for survival. It's important to have these feelings of anxiety in times of stress or danger. What happens when you walk out into the middle of the street and you nearly get hit by a Mack truck? What do? You jump back, your heart speeds up, you take deep breaths, you're sweating, you're breathing faster, your eyes are dilated, you may sweat a little bit. And that's normal. That's your fight or flight or your sympathetic nervous system kicking in to keep you safe. So what happens is your sympathetic nervous system kicks in, it elicits that response. That response is then carried over by the endocrine system, by the release of adrenaline in your body, until that perceived danger is over, and then the opposite, the parasympathetic nervous system, can kick in and bring everything back into a resting state. So it's very mechanical when you think about it. So I don't know if anybody remembers years ago, all these Toyota cars that were being recalled because the accelerators were getting stuck onto the floor and Toyotas were crashing all over the place. Well, again, think of your body as just a machine. If for some reason the nervous system is wired incorrectly, then it's not inconceivable to have these anxiety manifestations occur without the precipitating event. And that's really what anxiety is about. It's about these feelings of immediate impending danger without any rational cause behind that. And many people with anxiety disorder know there's nothing going on to cause these feelings, but they can't stop it either way. I'm sure everybody's probably heard about depression and major depressive disorder. And it's very common. It's definitely more common these days in lieu of this pandemic that's going on. But the medical illness depression is not just somebody who's feeling sorry for themselves or is having a bad day. Depression is an actual physical biological illness rooted in a lack of certain brain chemicals that bring about mood and affect. And everybody gets depressed. You have a breakup, you loss of a spouse, loss of a loved one, not getting the job you wanted. That's bereavement, that's situational depression, and that's a normal response to things that don't go our way. But clinical depression is a whole different story. This is a situation where just biologically people have alterations in mood, they have alterations in eating habits, sleeping habits that they just can't get themselves out of. And the bottom line between clinical depression and situational depression is, if most people who have situational depression can still go about doing their jobs, still go about taking care of their families, still go about doing their activities of daily living, where people with clinical or widespread depression generally have a hard time functioning in life. And when it interferes with the ability to function, that's when it becomes more of an illness or disease than just a situation. Bipolar disorder, or more commonly known as manic depressive disorder, is a situation where a person goes through extreme opposites of mood effect. It's not just somebody who has mood swings, but it's somebody whose mood can go one way. They can be extremely elated and manic and grandiose in their activity, in their socializing, in the way they do things, less spending of money, attempts to complete all these different tasks but never to completion. It sounds like a great thing, having all this energy and drive and ambition, but the problem is that most of these ambitions never come to an end. They never come to a closure. Projects are started that are never finished. Books are read that are never completed. There's person may deplete their whole bank account on stuff they have no need for, just for the pleasure of spending, until it goes to the opposite end of the spectrum, where they go into, again, a severe depressed, massively depressed episode, where they can't get out of bed, where they can't even feed themselves, where they can't even interact with society or feel any type of pleasure whatsoever. And this is a tough disorder to treat. It usually involves multiple medications and behavioral therapy as well. And schizophrenia is a well-known condition, but very little of it is well known. Schizophrenia is a constellation of a number of different conditions. What all have in common is person's difficulty in rooting themselves in reality and functioning day to day and maintaining themselves. What's very common in schizophrenia is a loss of touch with reality. Could be to a very minor degree, could be to a major degree. A minor degree where somebody may just hear some voices now and then, see some hallucinations now and then, to maybe a moderate degree to where their thoughts are disordered and random and chaotic, to a severe degree where they just can't even move or talk on their own without assistance. A lot of it is rooted, again, in how the chemistry in the brain works. And even though they don't know the absolute cause of schizophrenia, it is believed to be somewhat hereditary and genetic as well. So that's just a little bit of a talk about some of the more common illnesses that are out there. So, the textbook that you have gives way too much information about behavioral emergencies, more than I personally think is really appropriate for a first aid class. But bottom line, there really is no cause and effect for treating somebody with a psychological emergency, except that make sure that, one, you keep yourself safe. Two, think about all the medical or biological situations that be causing the situation. Three, talking to yourself and saying, how can I help? Or how can I not make things worse? Sometimes the best way to not make things worse is to not get involved. And just to call 911 if it happens to, or just let the situation play out. There is no one right answer. Best thing to do is keep your emotions under control. I mean, a person is having a psychiatric fit or an acute stressful reaction, they may lash out verbally, lash out, Hopefully not lash out physically, that's a different story, but they may be verbally abusive, abrasive, and you just got to think to yourself, especially if you're in any type of professional field like a nurse or an EMT, don't take it personally. Take it with a grain of salt. Does not affect your life. Listen to the individual, be honest. Don't tell them that something's going to happen if you know it's not going to happen. I never tell a patient that we're not going to take them to the hospital if we are indeed going to take them to the hospital, whether it be under police restraint or not. Never going to tell them that they're not going to get anything done if it is going to get done. Be honest. Never play into an individual's what we call psychosis. A psychosis involves a severe break in a patient's abilities to process information and interact with environments, often associated with schizophrenia. So different levels of psychosis include hallucinations. Now they could be visual or auditory. Visual hallucinations, seeing things that aren't there, are usually a result of substance abuse, some type of intoxication, some type of medication that induces that type of effect, like LSD or MDMA, as opposed to auditory hallucinations, hearing voices. That's usually more intrinsic to the disease itself. Now, most of the times when a person is having these auditory hallucinations, they are disturbing and distressful. Not always, though. Some people have auditory hallucinations that tell them nice things, but that's usually the exception to the rule. Delusions is a different story. A delusion is a false belief that's not rooted in any type of reality. So, for example, a person may believe that if they don't walk out of the house 3 times in a row, something bad is going to happen to them. They may believe that the FBI has implanted a microchip in their brain so aliens from another world can monitor them. But then how's that different than someone who carries a lucky rabbit's foot? Or how's that different from somebody who doesn't walk under a ladder because it's bad luck? How's that different from somebody saying, never say no-hitter in the 7th inning because you ruin the perfect game? The difference is, the difference that we're talking about is delusion versus superstition. Superstition is a false belief rooted in no actual evidence either. But the difference between that is most delusions inhibit a person's ability to function properly in the world. They'll avoid things that they shouldn't be avoiding. They'll avoid public situations. They'll avoid work. They'll avoid interaction with their family as a result of these delusions. Things that they need to avoid. They need to engage in order to continue with their life activities. So that's the problem with acute psychosis. And catatonia is a complete different situation where a person just doesn't respond or interact away, like the lights are on but the door's not open, or whatever the analogy. The door's open but the lights aren't on, but they just will stare into space and not talk and not interact. It's almost as if you're interacting with a wax dummy. I don't mean to use the word dummy, mannequin. And it's very very strange how this happens, and it's usually due to an imbalance of certain chemicals in the brain. It's a really good movie to watch if you ever have time. It's called Awakenings. It was back in the early 90s or late 80s, I'm not sure, with Robert Williams and Robert De Niro. Great movie about some of this type of disorder. In any event, emergency care for behavioral and psychiatric emergencies. Again, we're not really talking about the field of emergency responder. So we're talking about ourselves as people who are engaging with friends, family, coworkers, as people who are trained in first aid, who have made the decision to try to intervene when an emergency has happened. When I talk about behavioral emergencies to my EMT students, it's a whole big broader range of topics and interventions to talk about. when I talk about behavioral emergencies to my paramedic students, there's even more things to talk about, because now we're talking about certain drugs to administer and other certain protocols to administer. So really, the take-home point that I'd like to make as far as behavioral emergencies is really to, one, without going through all the details, one, always remember to keep yourself safe. Never put yourself in a situation where you might cause yourself harm. Don't ever be confrontational with somebody who's displaying bizarre or aggressive behavior, or even complete passive behavior. Three, try to remember that a lot of times the causes of most behavioral emergencies are biological or medical, or something actually organic as the root cause. And think about what you can do to remedy that, if it can be done at all. And again, the situation comes down to it, have a low threshold for calling 911 if that has to be done. Another thing to talk about is suicide. There's been an increase in suicides over the last 8 months due to everything that's been going on with the situation. So I think the statistics that you have here on the slide are probably a little outdated, and it's okay, because I'll never test you on statistics to begin with. But just understand that suicide is definitely something to be taken seriously. And a lot of times it'll take people by surprise. They talk about risk factors for suicide, warning signs, and there are warning signs. Most people don't pick up on the warning signs until after the fact, in retrospect. Some of the warning signs is somebody who's gone through a history of depression. Some of the risk factors are history of substance abuse, somebody who's recently gone through a breakup or a job loss, somebody who possesses a firearm are more likely to commit suicide. But in any event, a lot of times people who are overdramatic will say, I want to kill myself, and never follow through with it. What worries me is somebody who has a well thought out plan to commit suicide. Somebody who says, I want to go out to where the L train stops at 3 o'clock in the morning so nobody sees me. I'm going to wait for that next train, and I'm going to jump on the tracks and make sure nobody's there to stop me. That's a plan. That's somebody who has things well thought out. Another risk factor or another warning sign for suicide is somebody who's gone through a real deep depression and melancholy mood for the longest time, then all of a sudden seems to snap out of it, and out of nowhere, and seems more at peace with things. That's somebody who's actually at risk for suicide, believe it or not, because more than likely they've made the decision to end things. They think that that's going to end all the pain. They think that's going to put their minds at ease, and they become at peace with it. And then people most often think, oh, he's getting so much better. And then, lo and behold, boom, the situation occurs. And, a lot of times you'll hear people say, oh my God, what the hell was he thinking? He's got a family, he's got a job, he just left 2 daughters alone all by themselves. And people will react to the news of suicide with anger and hostility and all sorts of mix of emotions. But nobody, and I mean nobody, not even probably the most brilliant minds in the psychiatric field, can know what's going on in an individual's mind the moment they make that decision. They don't know if there's actually a linear, tangible train of thought, or if anything's just been thrown out the door. Just like, for example, you're taking a bunch of building blocks and make structured tower, and that structured tower is your thought process, and all of a sudden that tower just comes crashing down, and that's all your thoughts. That's probably what's going on, So even though it's easy to have that thought process, you got to understand that probably when somebody pulls that trigger or makes that jump, those thoughts are not reality to them anymore at that point. And again, it's always best to take those warning signs and opt for the side of safety and err on the side of safety rather than just to be passive about it. So if no questions about anything we've talked about right now, let's take a 10-minute break, and then we'll continue and we'll talk about poisoning and overdose emergencies, or substance abuse, I'd like to talk about. Any immediate questions? All right, see you guys in 10, or talk to you guys. You can hear me. Anyway. Hey, oh, wonderful. Okay, so anyway, we're going to be talking about starting off with poisoning and then overdose emergencies, which is going to dwell a little bit into the field of substance abuse, at least from an EMS provider's point of view and a first aid point of view. I'm not going to go too much. Again, your textbook, I think, goes way too much detail into the chapter of poisoning. We're not studying to be toxicologists, and I don't expect you to know the specific sign and symptom and intervention for every single poison, every single dangerous substance on the face of the earth, because that's ridiculous. There are general first aid considerations to know that I would hope that you pick up on. First of all, knowing what a poison is. Poison is any substance that can harm the body. Simple as that. A poison could be almost anything in enough quantity. Uh, Mercury is a poison. Cocaine is a poison. Uh, Even water can be poisonous, believe it or not, if it's in enough quantity. It could be poisoned water. There's a condition called water intoxication. I'll talk about that a little bit later on. In any event, just about anything that can get into your body in sufficient quantities can be a poison, including medications, including food, including plants, you name it. So how to classify poisons? We basically classify poisons on how they get into the body. And a poison, the substance can get, yep, absolutely. A poisonous substance can be just about anything. There's only 4 ways that it can get into the body. You can either inhale it through the lungs, ingest it through the digestive system, you can absorb it through your skin, or you can inject it into the deeper tissues, into the muscle, into the vein itself. So it goes right in. So anyway, what's an example of what would be an ingested poison, for example? Well, probably just about anything you can think of. Food, drugs, chemical cleaners, cosmetics. Sometimes we don't even think about that. You know, if you have all these different colored eyeshadows, what does that look like to a 4-year-old? It looks like candies. Those are all things to consider. Cough medicine, especially these Flintstones chewable vitamins, things that are candy tasting. You know, I see a problem with these medications, these cold and cough remedies, these gummy bear preparations. I mean, yeah, you want your child to take medicine, but you don't want to enjoy it so much that they say, "Oh, wow, this tastes great," and next thing you know, there's a half a bottle empty. You know, something as simple as Tylenol. You know, Tylenol is actually a pretty poisonous substance. It only takes about 20 pills at one time to completely shut down the liver and kill you over the course of 7 days. So we're going to talk about the intervention for ingested poisons in a few moments. The question is, well, what do? Do you make them throw up? Do you give them water? Do you dilute it with milk? We'll talk about inhaled poison. I mean, that's a way of getting into your bloodstream through the airway, through the alveoli, and into the capillaries. I mean, what's an inhaled medication? Anesthesia. I mean, too much anesthesia is what? It's a poison. Well, what are more common poisons that are introduced by inhalation route? Well, very common, very important one is carbon monoxide. Carbon monoxide is basically a byproduct of combustion, of something burning. It's as opposed to carbon dioxide, which has two atoms of oxygen. Carbon monoxide is one carbon, one oxygen. And how does carbon monoxide kill you? Well, really, it's very simple. Your red blood cell has hemoglobin in it, which carries a molecule of oxygen throughout the bloodstream to deliver to the cell for metabolism. That hemoglobin is much more attracted to a molecule of carbon monoxide than it is to a molecule of oxygen. So if one for one, if there's a carbon monoxide molecule next to an oxygen molecule, that carbon monoxide is going to bump that oxygen out of the way, and it's going to saturate that red blood cell. So that red blood cell is going to be full of carbon monoxide, which is plain, until it gets to the cellular level, because the cell cannot use carbon monoxide for metabolism. So the cell metabolizes anaerobically without oxygen. It builds up of acids and ketones, and the cell ultimately dies. And that's how carbon monoxide poisons you. Smoke inhalation, if you've been pulled out through a fire, you've been in a burning building for the last 10 minutes and you made your way out. Great, thank God you haven't been burned alive, but you've inhaled all the smoke. Common byproduct of smoke is cyanide. What does cyanide do? Cyanide poisons you at the cellular level, where the mitochondria cannot produce any energy. And the treatment for cyanide poisoning is very, very complex, and nothing that can really be done at the first aid level. Just think about mixtures of chemicals. I'll tell you a personal story, which, being an EMT and first aid instructor is kind of embarrassing. When I first bought my house years and years ago, the upstairs bedroom needed a little work on it. Had this old, disgusting 30-year-old carpet with all this mold and pet stains on it. It was so disgusting that you couldn't really. I took it off the floor, and you really couldn't tell where the floor began and where the carpet began. So it took me a long time to rip all this carpeting open, scrape it off the floor, and really scrub the floor down. And then I figured, what, I'm going to give this floor a good cleaning with some bleach. I put some bleach on the floor, mopped it around, and all of a sudden I started feeling dizzy and getting tight in the chest. Well, what did I not consider? I put bleach on the floor, but what had been seeping through that carpet over the last 30 years before I bought that house? Dog pee. Well, what's one thing that's found in dog pee, or anybody's pee for that matter? Probably more so in cat pee. Absolutely, Delfino. Ammonia. So urine has ammonia. That's right, Joyce. Oh boy. So anybody knows anything, just a little bit of chemistry knows when ammonia and bleach are mixed together, it lets off a poisonous gas called phosgene, which the Germans used in World War I as a form of chemical warfare. So very poisonous to the lungs. So needless to say, I had to get out of that room real quickly, and I spent the next night sleeping in the backyard. So don't ever mix cleaning products together, because you could be definitely in for a treat. Yeah. So we talked about ingested poisons, inhaled poisons. I mean, the treatment for inhaled poison is, if it's safe to do so, get that person away from the source of the poisoning and call 911, and don't get yourself exposed in the process. We'll be an example of an absorbed poison that goes through the skin and causes trouble. Some people would say poison ivy, for example. Poison ivy is a degree, yeah, it's really not a poison in the sense that poison ivy really doesn't get into your bloodstream from where it's at. Poison ivy is a rotten situation to have. Poison ivy, poison sumac, poison oak. All these plants release chemicals that many people are highly sensitive to. And the real treatment for poison ivy isn't just a little topical calamine lotion. Some of these situations require about 3 weeks of tapering steroid therapy to really, really get it under control. I mean, I saw a lot of this among landscaper workers who came into the state after Hurricane Sandy, clearing away all the brushes from all over the city. A lot of them wound up in my ER with all these welts and blisters all over the arms and legs, all from the poison ivy they came into contact with. But a more significant source of an absorbed poison might be somebody's medication patch. Some people wear medication lotions on a patch that slowly gets absorbed through the skin and releases that medication into the bloodstream over a course of time. An example that would be nitroglycerin. We talked about nitroglycerin in cardiac emergencies. It's a medication that helps opens up the blood vessels. Some people have nitroglycerin paste applied onto their skin to slowly release nitroglycerin into their system several hours a day. You touch that, you wind up getting into your system, your blood vessels are going to open up, they're going to dilate, you're going to get dizzy, you're going to faint. Another common source of transdermal or absorbed poison that I tend to see in the ER a lot is, and it's unfortunate as well, people from long-term care facilities who are on pain patches, fentanyl patches, which release a steady amount of narcotic pain reliever into their system. And those patches are usually good for 72 hours. And somebody's not looking or not paying attention to what they're doing, they'll put a new patch on and forget the old patch off. So they're getting a potent dose of new fentanyl, but they still have a little bit of fentanyl going into their system. And they come into my ER all gorked out and barely breathing because somebody basically just overdosed them on narcotics. So another thing to consider. And what about injected poisons? Well, an example of injected poison might be something like venom from a snake or a scorpion. We may talk a little bit about that next week. I'm not a big expert on wildlife wilderness first aid. Injected poisons from syringes from illicit drug use. Just watching a documentary and reading up on this new type of heroin out in Russia and Europe called crocodile, which is so toxic. When somebody injects it into their system, the chemical itself just basically eats away at the flesh, almost like a fish eating bacteria. People wind up getting ulcers and sores and losing patches of skin, and just basically eats them away to the bone. It's a disgusting thing when you think about it. In any event, so as far as ingested poisons goes, who's more likely to accidentally ingest a poison or swallow a poison? Usually a child. Usually because the smaller they are, how do they learn about the world? They put everything in their mouth. They can't read the warning labels, especially if something is brightly colored, like maybe a bottle of Mr. or Pine Sol, which looks like lemon juice or orange juice to them. They don't know the difference. Whereas an adult, it's usually either a deliberate attempt at trying to hurt themselves, or sometimes, which you see more in the elderly, is medication misuse. If one is good, three's got to be better. That's not inconceivable you see something like that. So what are some basic guidelines when confronting somebody who's been poisoned by any means? There's some information you want to try to get a hold of. Well, I mean, first of all, let's backtrack. Obviously, you want to make sure they're awake. Obviously, you want to make sure they have an open airway. You want to make sure they're breathing adequately. You want to make sure they have a pulse that's showing signs of shock. Those are the first things you have to address no matter what. Then you want to ask yourself what substance was involved. Was it cleaning fluid? Was it insecticide? Horrible agents and insecticides. When did the exposure occur? Did it occur? And not only when did it occur, was it 20 minutes ago, but over the course of how long did it occur? Was it a quick flash exposure where boom, they just got it in their face, or they took a whiff of something, or they swallowed a bottle of pills all at once? 20 pills, one shot versus 20 pills over the course of the last 8 hours, it's going to be metabolized a lot different. How much was ingested or taken into the body, if that can be determined? Were any interventions taken already? Did the person try to make themselves throw up? Did they try to counteract the agent with anything? You'll see some people try to do. Why is weight such an important thing? Well, think about it. An overdose of 20 Benadryls is going to affect a than a 200-pound person who has more muscle mass, more body fluid to distribute that chemical around and to eliminate that chemical. And what effects have the patients experienced? Are they nauseous? Are they vomiting? Are they seeing double? Are they having burning in their vision? Are they losing consciousness? Are they short of breath? Are they having chest pain? There is an old, basically outdated, antiquated intervention for some ingested poisons was something called activated charcoal, which is really not recommended anymore. Activated charcoal is just what it sounds like. It's liquid slurry of dark charcoal bits, highly carbon-based. It looks like bloody diarrhea, and the way it goes in is usually the way it comes out. And the purpose, or the theoretical purpose, of activated charcoal is to bind to any type of pills or substances that may be in the digestive tract that haven't absorbed yet, and allow it to come out the other end before it gets into the bloodstream. Problem with activated charcoal is by the time, first of all, you got to convince the person to drink it. You can't just hold their nose and force it down their throat. So if somebody's intentionally overdosed a bottle of Tylenol, chances are they're probably not going to be too cooperative in drinking a bottle of something that looks like bloody diarrhea. Second of all, by the time most people notice that this has happened, a significant amount of this material has been absorbed anyway. And if a person has ingested any type of corrosive or caustic material, like a drain cleaner, for example, or gasoline or kerosene or anything like that, that's going to cause burning in the esophagus, burning in the stomach. And the problem with giving activated charcoal is it's going to cover the lining of that area. And then when that person gets to the ER, they're going to want to go look at that lining through a scope, and they're not going to be able to see the extent of damage that's been done to that digestive tract. It's not an antidote to anything. There are very few antidotes available to most poisons, not only in the first aid world, but even in the EMS world as well. But we'll talk more about antidotes in a few minutes. One antidote that we want to talk about, and I really would like you to watch the video on under course sites, is something called naloxone, or Narcan, which is used in the case of opiate poisonings or narcotics overdose. A lot of controversy over that stuff. In any event, again, make sure that before you intervene in any poisoning situation, you make sure the scene is safe. If somebody sees, like we see in the picture here, somebody in an enclosed garage who's passed out by a motor vehicle, you know what caused them to pass out, and you obviously see these firefighters in self-contained breathing apparatus rescuing this person from the scene. Don't you be the person that has to be pulled out by the firefighters. You should be familiar with your local and national poison control center. And there's a nationwide universal number, 1-800-222-1222. It's absolutely impossible to memorize and learn the treatment and antidotes for every single poisoning in the world. It's impossible. Even in the emergency room, we can't do it. 9 times out of 10, if I have some type of overdose or poison victim in the emergency room, I will call upon the local poison control center for aid and advice on how to proceed with this poisoning. You know, whether they've overdosed on some psychiatric medications, on some unknown substance, so whether they come to contact with some type of corrosive cleaner, it's an absolute vital resource because they work on a whole computerized database of all sorts of different substances, just basically almost everything known to Earth. And they're trained toxicologists, medical doctors who are trained to specialize in this field. So the take-home point for poisoning is general care for poisoning really comes down to two situations. Your victim is either unresponsive or they're responsive. If they're unresponsive, well, don't even bother with poison control. Call 911 immediately. Attend to the victim's airway, breathing, circulation. If they're completely unconscious, keep them. If there's no evidence of injury or trauma, leave them over to their side in the recovery position and monitor their condition. If the victim is responsive, again, assess the airway, breathing, circulation, call the poison control hotline, gather as much information as possible. Okay, what did they take? How much did they take? Over what course of time did they take? How much does this person weigh? Do they have any other medical issues that may compound the emergency of the overdose? And did anybody try to do anything to try to intervene, follow their guidelines? And what you see at the bottom is never, never, never try to induce vomiting or attempt to give some type of antidote unless instructed by poison control. For example, if somebody were to overdose on some Tylenol PM, for example, and you took it upon yourself to to try to make them vomit. I don't know if anybody's old enough to remember something called syrup of ipecac. It used to be carried in first aid kits. It was this nasty thing. You make somebody swallow, follow up a drink of water, and it would make them vomit like The Exorcist. Probably some of you guys don't even know what that reference is about. But the problem is, by the time that vomiting agent takes effect, the Tylenol PM has probably already made this person partially sleepy, if not out cold. It's the problem with inducing vomiting if somebody loses consciousness. Boom. They're going to inhale their own vomitus. They're going to have an aspiration pneumonia, and they're going to have even more of a problem. So don't do it unless poison control tells you. Very rarely do they advise you to induce vomiting to somebody who's ingested anything. Don't try to dilute with water or milk or anything just like that, because you never know if there's something that has to wind up going to the OR for whatever reason. If something in their stomach that should be there, it's only going to cause problems once they go under anesthesia. Questions about poisoning? So the last thing I would like to talk about is some trends in substance abuse. And trends in substance abuse, it's such an ongoing and evolving and changing topic that by the time I update it this semester, there's new issues to be addressed. So it's really something that I think I talked about early in the year, how medical issues change so much faster than textbooks can keep up with. This is absolutely one of those situations. But so let's understand one term, substance abuse. Just in case we don't know, it's a chemical substance that's being taken for other than therapeutic medical reasons, usually for some self-indulgence like getting high or relaxation or something to that effect. So at this point, I want to throw out a question to you guys, and please be honest with your opinions. If you have a reason behind your opinion, I'd like to even see that even better. Answer this question. Is addiction a choice? Does anybody think yes? Does anybody think no? Okay. See, this is what I miss about being in class personally, because usually when we get to this point of the class, I would break you guys up into small groups of 4 or 5, have you discuss it amongst yourselves, and send a representative up to the class one at a time to defend your argument. But so only 2 people answered me. I'm hoping other people are pondering in their head if they really want to answer that or not. It's not an easy question. I got a couple of very hard no's, and that's interesting. And probably some people are probably saying, just keep pondering, Javante. Okay, you do that. Maybe some people are just too shy, or maybe they're not sure and they don't want to give their answer. That's okay. It's okay. It's not an easy question to answer. It really isn't. But to answer it, first we got to know what addiction is. And we want to compare and contrast it to some terms that we commonly hear when we talk about this subject. So what is addiction versus dependency? Versus tolerance to withdrawal. So I told you, teaching a class next semester, it's called Addictions and Dependencies. It kind of goes beyond the little scope of its title. But a lot of those times, those 2 terms are used interchangeably, but they're really different terms. So addiction, for example. I'll give you an example of my addiction. So a time when I worked in the Bronx, for example, my shift would start at 7 a.m. I would get up at 5:15, leave the house by 5:45. I would stop at the 7-Eleven right before I got to the Southern State High. You know me so well, Joyce, don't you? I would stop at the 7-Eleven before I got onto the Southern State Highway, and if I got to the Southern State at 6 o'clock, first I needed the 7-Eleven has this what's called Brazilian Bowl, this really dark roast that's awesome, and I would just that would start my commute from Long Island into the Bronx, and I'd be a very happy person. So if I got onto the Southern State at 6 o'clock, I usually had it timed pretty well, barring any emergencies, that I would get to the parking garage about 6:50, park the car, and I'd be right in on time to start my shift, maybe even a couple of minutes to spare. Now, what do you think would happen if my alarm clock didn't go off, or I had a problem with the dog, they pooped all over the living room and I had to clean it up, or any other circumstance happened? You guys pretty much know how rush hour traffic is, right? If I leave at 6 o'clock, if I get on the highway at 6 o'clock, I get there I'm supposed to be at 10 to 7. If I get on that highway at 6:10, do you think I'm going to be where I'm supposed to be at 7 o'clock? No. That 10 minutes makes a big difference. If I'm 10 minutes late on the highway, I'm 30 minutes late getting off the highway. It's like a time warp type of thing. So that being said and that being understood, if something keeps me from leaving my house at 5:45, do you think I'm going to not go to 7-Eleven and not get my coffee even though I know it's going to make me late and people pissed off at me? Absolutely not. I'm getting my damn Brazilian bowl, and you're just going to have to deal with it. So that's a little bit of addiction, isn't that there? A modification or some type of behavioral situation where I'm trying to get something that I perceive as pleasurable, despite what I know are going to be negative consequences from that behavior, from that choice. So a little bit of a choice on my part. As opposed to a dependency is when your body chemically becomes linked to that agent that you have a connection to. That's a good question. Delphine asked, do I physically have consequences if I do not get that coffee? Yes, they are, because I am somewhat physically dependent on that caffeine as well. Physical consequences, meaning I'll get pissed off at every freaking driver on the highway. I will get pissed off at every freaking snot-nosed intern that gives me a hard time in the ER. I may yell and grunt at people. I also might get a severe headache too. Yes, you're right, Delphina. Headaches are a result of what's called caffeine withdrawal. And that's the other term I wanted to talk about. Withdrawal is that state of unpleasant feelings due to deprivation of that substance that you are so in turn dependent upon. And that's one of the negative reinforcers that helps lead to addiction. And then, of course, there's tolerance. Tolerance means that you need more and more of that substance to derive the same effect or even come close to the same effect. So you figure my beautiful Brazilian bowl coffee started out as a 10-ounce cup. 10-ounce cup went to 12 ounces. 12 ounces went to 16 ounces. 16 ounces couldn't do the job, so now I got the biggest 24-hour cups. And then finally, it got to the point where I was just taking those big gulp cups and putting them right under the coffee containers and just chugging them down all the way down to Montefiore Hospital. But yeah, so that's basically tolerance. Now, when you talk about tolerance when it comes to substance abuse, it's a little bit of a different story, because most times when people try that first agent, whether it's that first hit of heroin, cocaine, methamphetamine, they get this unbelievably massive high. But that only occurs the first few times, and then what happens is the body tends to become sensitive to this agent, so they find that they need more and more of this substance to derive that same amount of pleasure. And even that point, even with more levels, those pleasure sensors are diminishing. So it gets to a point where we need even more and more, not just to feel pleasure anymore, but to avoid that situation that we talked about with the withdrawal, which we don't want to experience. Now, some substances, the withdrawal situation can become quite unpleasant. Other substances, withdrawal situation can actually be life-threatening. But let's go back into the physiology of addiction and dependency and understand that any illicit substance of abuse, whether it's cocaine, heroin, marijuana, alcohol, Valium, all have one thing in common, is that they affect certain chemicals in the brain that affect all sorts of things: mood, affect, uh, awareness. And now, this is an oversimplification by all means, but three of the major players in this concept are serotonin, norepinephrine, and dopamine. Um, for example, serotonin is important in feeling of calmness and satiety after you've had a meal. Norepinephrine is important for levels of awareness and activity. Dopamine has its roots in stimulating what's called a reward mechanism or feeling of pleasure. When you bite into that chocolate bar that you've been craving for the longest time and you're like, oh, that was so good. What's going on is that chocolate has caused your brain to release this chemical called dopamine to actually, it's like a quarterback throwing a pass, a beautifully timed pass to that wide receiver, scoring a touchdown. Okay, so that dopamine is getting sent to that wide receiver, or that receptor in that brain, that part of the brain that is responsible for pleasure is stimulated, and boom, you just got that intense feeling of pleasure. And that's a very, very important survival mechanism, believe it or not. If you think about it, as a human biological species, why do we reproduce sexually? And yeah, some of you are going to say, because it's fucking fun, it feels good. Well, yeah, right. But there are other life forms that reproduce just by breaking off a piece, like a cactus breaks off a piece of its limb, gets carried through the desert, and a new cactus is born, like a bud. You think that would be a very, very efficient way to, although not boring, way to reproduce. And it works for some species, but not for all. So if you're a cactus in the desert and you reproduce just by breaking off a part and making a carbon copy of yourself, that may work great until environmental situations, the world change, until some type of new bacteria or fungus is introduced into the environment, until there's a massive environmental changes like weather changes, temperature changes, in which your species cannot survive. But because every species is genetically a carbon copy of itself, one dies, they all die. So by reproducing sexually, we're constantly reshuffling our genetic deck so that on the whole, as a large species, any species, whether it be human, polar bear, whatever, some can survive environmental changes, some don't survive, but the species itself survives. Now, did we know this as cave people going into the field? Did we know that we had to reproduce like this so we could propagate our genes to survive environmental anomalies? Absolutely not. We knew that we had to reproduce sexually because it felt freaking good. And the reason for that was that dopamine drive that drove that behavior for survival. Well, that's what these chemicals of addiction, cocaine, heroin, methamphetamine, alcohol, all in one way, shape, or another, tend to reproduce, leading to that addictive personality, leading to that state of dependence. So there's a little thought there. Now, is that to say that, nobody ever made that choice to pick up that first syringe, or nobody ever made that choice to pick up the first shot glass? No. The answer to that original question is not black and white. There's a lot of variables in between. So let's talk a little bit about alcoholism, which is because alcohol is, by and large, the most commonly abused substance, mind-altering substance in the world, and most readily available usually. So I'm sure that this picture here obviously represents what a typical alcoholic looks like, doesn't it? If anybody's agreeing, disagreeing, no, absolutely not. This is what maybe a stereotypical picture of an alcoholic looks like, but a more realistic depiction of what an alcoholic might look like would be depicted in this photo. Could be your doctor, could be your accountant, could be your family man father, could be your grandmother, could be your athlete, could be your college student, could be your high school student. It knows no boundaries. I mean, there are some social and demographic factors that may contribute to alcoholism or prevalence of alcoholism more than others, but by and large, there is really no no race, no ethnicity, no social class that's really immune to this disease. And yes, again, I call it a disease. As far as alcohol overdose goes, we see it in EMS all the time. And again, we tend to have a more callous attitude towards it, you know, maybe somewhat because of what we've seen growing up, because again, it's hard to deal and manage with the behavior and the behavior abnormalities that come with alcoholism and alcohol overdose. But it's often not thought of as a serious problem. Oh God, just another drunk, throw him on the bed, let's get him going. So providers tend to get callous towards it. They tend to toughen themselves up mentally and emotionally, maybe for some defense mechanisms, maybe because of burnout. But what I try to instill in my students and my coworkers is, you know, people who are drunk are not immune to disease. People who are intoxicated are not immune to trauma. Just because somebody's drunk or intoxicated does not mean there's nothing else ever going on. And alcoholics do have a higher potential than other people with certain medical conditions, which we'll talk about in a minute. So what do you see on a person who's suffering from alcohol abuse? Well, the odor of alcohol in that person, that pungent, displeasant smell on their breath, unsteady gait, kind of shuffling or staggering gait, slurring speech and incoherent words as the speech center in the cerebrum is affected. Maybe nausea and vomiting to some degree if they've overdone it. And of course, mental status changes as well. But again, as I tried to make a point earlier, all of this could be a result of a serious medical problem as well. Diabetes, stroke, electrolyte imbalance, head trauma, infection, sepsis, something of that good. Just to name a few. And that's what unfortunately, a lot of pre-hospital providers that I see these days, and in-hospital providers for that matter as well, sometimes forget about or even negligent about thinking. So, and if we don't look for it, we won't find it. And of course, there's so many personal injury lawyers in the world that makes medicine a pleasure to deal with. So those are some of the physical problems associated with chronic alcohol abuse. One of which is something called esophageal varices. This is a scope of somebody's esophagus. Inside of the esophagus, if you look at a regular picture, what I should probably have lined up here, it should be smooth on all ends. What you're seeing, all these bubbles and bumps or ridges, are this stretched out, distended, dilated vein along the esophagus. Basically, the same thing that happens with a hemorrhoid. A hemorrhoid is a dilated, bulging vein in the anal canal, which can rupture and cause severe bleeding. Well, the exact same thing can happen here in the esophagus. As one of these blood vessels rupture and bleed, it can cause severe bright red vomiting of blood in this individual. You may have heard the term cirrhosis. Cirrhosis is a wearing away and a scarring and the ultimate destruction of the liver. And the liver is important for so many different functions in the body, detoxifying the blood, creating certain digestive substances, helping produce clotting factors so the blood clots properly, producing proteins to allow proper distribution of fluids in the body. And sometimes cirrhotic livers can lead to liver cancer. And liver cancer never really has a good prognosis. But just a picture of what liver failure looks like here. What you're looking at is somebody with a condition called ascites, which is not uncommon in your alcoholics. Look at that big, huge belly. She's not pregnant. If you look at the size of her arms and her face, that belly is proportionally a lot bigger than the rest of her body. And the reason that's happening is because that belly is accumulating a whole bunch of fluid in it called ascites because the liver is in failure and it's not maintaining the proper vascular space that it should be maintaining. So generally what they have to do is go in with a big, huge needle and drain that, and then they had to address the liver issues. It never really has a great outcome. What you commonly see in alcohol, that we don't commonly see because you don't have x-ray eyes, but alcohol does cause the brain to physically shrink, a process we call atrophy. And you can see in the picture here, the brain of a normal 43-year-old versus the brain of a 43-year-old alcoholic. The brain is shrinking, there's less tissue, less mass, more room for it to rattle around in the skull, which can be particularly problematic when the person falls down or when they hit their head, because that can lead to another situation that's common in alcoholism called a subdural hematoma. I think we talked about that when we talked about CNS injuries. What you're looking right here is blood that's separating the brain from the skull, pushing pressure onto the brain. And the reason why alcoholics are prone to this is twofold. One, alcohol inhibits the liver's ability to create certain proteins that helps the clotting process. So alcoholics bleed easier. Also the fact that because they have those shrinking, atrophied brains, the brain tends to rattle in the skull, tearing apart the blood vessels that bridge the brain to the skull itself as well. So it's a double-edged sword. No, we're talking about not occasionally. No, actually, believe it or not, an occasional drink can actually be considered protective against things like heart disease and stroke. That's a whole other story. We're talking about alcoholism, which is chronic alcohol abuse. I mean, we're talking about daily use over a prolonged period of time. Another issue that we have out there is narcotics. Now, there is a definite medical role for narcotics. When you're talking about somebody who's suffering from cancer pain or post-op pain, the use of narcotic pain intervention is integral, especially if somebody's at the end of life in the hospice. I mean, you really want to let them have as much of a comfortable and dignified death as possible. But all narcotics, morphine, heroin, opiate, anything, all stems from opium, a substance called opium, which comes from the poppy plant, which basically it's this big bulb type looking plant. It's really hard to mistake, which once it's cut open, it releases this dried up sap, which can be mixed up into a gum, which can be processed into something called opium, which can further, and opium's been around for centuries. There's even records of it being around since before biblical times. And opium itself is relatively mild in its effect compared to what it can be processed into. And so, opium plants can be grown all sorts of places. Colombia, Peru, China. China was a big producer a couple of centuries ago, which led to a lot of historical laws. Yeah, exactly. But does anybody know what country produces about 90% of the world's opium supply? Any ideas? It's always been a huge player. Very good, Delfino. Yeah, Afghanistan. Yeah. Back in the 80s, when you had, Afghanistan, the Soviet Union, former Soviet Union, Russia trying to invade Afghanistan, the Afghanistan armies basically funded their defense through the selling of the opium trade, and then took a little dip back in 2001 with the United States invasion of Afghanistan, but then it's hit a big resurgence again. And so what does opium ultimately lead to? In the mid-19th century, scientists were able to extract opium and develop chemical morphine, which even to today's date is the standard of which all other painkillers are measured up against. It has a very important medical role. It was advertised for just about anything. Cure for opium addiction, well, curing opium with a strong opium. Cure for alcoholism, never true, of course. Being addicted to morphine was preferred over being addicted to alcohol because morphine addicts just kind of withdrew from the world. They didn't get the bar fights, they didn't beat their wives, they didn't cause a ruckus. And it's also known as a soldier's disease because it was really a godsend to Civil War soldiers were who would get their limbs blown off, who would get hacked with bayonets. If you were a Civil War soldier and you got shot up in one of your limbs, the only treatment for it was getting it chopped off. And there was no anesthesia, there was no medical great painkillers. You just basically had a surgeon who had three tools: a hacksaw, a pruning knife, and wire cutters. The pruning knife was through your flesh. The wire cutters were to cut through your ligaments and tendons. And the hacksaw was to cut through that bone. And best bet type of anesthesia that the soldier could possibly have would maybe be a half a bottle of whiskey and the other soldiers holding him down. So that surgeon had to work fast. Morphine was introduced. It helped ease the pain somewhat of limb amputation. It also comforted people who were dying. And overall, it was a highly coveted drug back then, and not legal and not regulated. Neither was this wonder drug that was introduced in the late 19th century. The Bayer Pharmaceutical Company actually came up with two miracle drugs that at the time. One was aspirin, which is still used today as a fever reducer and mild pain reliever, although can be very, very rough on the stomach. And the other very highly coveted drug that was produced by the Bayer Pharmaceutical Company was heroin. Heroin was a highly coveted drug. Does anybody know what heroin was marketed for originally? It's a little blurry, but you could probably read it on the slide. Heroin was an extremely effective and potent cough suppressant. It's like, cough suppressant, really? Wow, why was that such a big deal? Well, in crowded city conditions, what do you think most people died of in New York and other crowded cities back in the late 1800s? Anybody know probably one of the biggest killers? Flu is a good guess, Olga, but that was really more towards 1918 was a bigger killer. Around 1890, bigger killer than even that, especially in the crowded areas. Tuberculosis. And tuberculosis, obviously, it's a respiratory pathogen that's transmitted by coughing and breathing. And so this drug that helped suppress the coughing reflex, if not even knocked out, was a highly coveted drug because it comforted people who were dying of tuberculosis, but it also helped prevent the spread of tuberculosis as well. So it was really, the governments really had no problems with heroin until some other situation came about, stemming in racism, which you saw from my course next semester we could talk about in depth. But it was perfectly legal and perfectly available back in the 1800s. So what does heroin actually do to the body, as opposed to opiates, really? Well, they work in three ways. Well, there's part of the brain called the limbic system, which controls your emotions of feelings of pleasure. And this is where heroin and opium stimulates those dopamine receptors to give that profound sense of euphoria and pleasure. Opiates also stimulate areas in the spinal cord which receive and interpret responses. So when you perceive pain, you actually have chemical nerve receptors called pain receptors. Kappa, beta, and morphine actually blocks those receptors, kind of like, a defensive end or defensive back, blocking the wide receiver from catching the ball. And in the brainstem, opiates tend to numb activity in the brainstem as well. And what's the important activity in the brainstem? Regulating your breathing. So that's how opiate or morphine addicts or heroin addicts usually die, because they stop breathing. Now, typically, you would think of the heroin addict as that kind of unkempt individual lolling around in dark city alleys or in abandoned buildings, shooting up with hypodermic syringes. And that's the most efficient way to get that chemical into the bloodstream, is by injecting it directly into the vein. It takes about 10 seconds for the effects to get to the brain. But as we're going to talk about a little later on, a lot of your opiate overdoses, including prescription medications and heroin, are almost just as prevalent in the suburbs and rural areas as they are in the inner city, if you go on a per capita basis. So it's not just the slums and the ghettos where you're finding this. It's everywhere. It's widespread. That's why it's considered an opioid epidemic. Some of the problems associated with heroin usage in particular, because heroin is most commonly introduced through the use of syringes, needles into the skin. Well, one can be an abscess formation. Dirty syringes lead to bacteria into the skin, causing boils and surrounding infection called cellulitis. I think everybody's learned since grade school that sharing of syringes can lead to hepatitis B and more often hepatitis C. Again, this is another example of what happens with hepatitis leads to liver failure, this accumulation of, and this is just one of the manifestations of IV drug abuse. Okay, sorry for that little pause. And I'm sure everybody knows about the relation between uh, IV drug use and HIV and AIDS. Was probably one of the most common, even though AIDS is on the decline these days, it's still one of the most common causes of AIDS. And so to look at there's some very uh, typical manifestations of opiate overdose if you're examining somebody or evaluating somebody, one of which is if you look at the pupils of their eyes, they tend to be very constricted and pinpoint. It's normal for the pupils to constrict when light is shined in the pupils, but to the point where they're almost the size of a pin, that's pretty common with heroin overdose. Sluggishness, unresponsiveness, sometimes to the point where they're completely unconscious and barely breathing. It's not common to see the heroin overdose on the floor, blue in the face, showing what's called agonal respirations. Instead of nice normal breathing, it's kind of just a little grunt and a gasp every maybe 6 to 10 seconds. Something like that. Now, what's an important thing to know about is an important video I'd like to watch on your menu is that the activity of opiates and heroin can be temporarily reversed with this drug called naloxone, otherwise known as Narcan. Commonly, it was only found on EMS ambulances, paramedic ambulances. Then as the opiate epidemic started growing, they started making it available to EMT basics. Um, it can be introduced in a number of ways. As paramedics, we can administer it intravenously through the muscle, and EMTs actually administer it by spraying it through the nose where it gets absorbed through the nasal passages. And this has become a very, very important public health initiative because naloxone is now available to the lay public. So if you're an individual who has a family member who's, is prone to having heroin overdoses, you can actually not get a prescription, but you actually purchase Narcan in the drugstore and have it on hand just in case your family member or somebody you know overdoes it and they're in death. Unfortunately, not everybody gets a naloxone on time. And if that's the case, it does lead to death. And heroin overdose and opiate overdose is a significant cause of premature death, not much in the inner cities, but actually in the suburbs as well. And it's not just the IV heroin that's the big problem these days, but more so prescription painkillers. Oxycodone, OxyContin, I'm sure you've heard of all of them. And even though it's on the decline, it was a big push back in the early 21st century by pharmaceutical companies, Purdue in particular, to push for these really, really potent, supposedly non-addicting painkillers called OxyContin. And there was also a political push for regulatory agencies of hospitals, Joint Commission, to really threaten sanctions on hospitals and healthcare providers if they did not adequately address pain. I can give you a personal circumstance that just shows how out of control this was. It was 2005. I myself, I had some surgery over in the hospital in Manhattan at Sloan Kettering. I had a benign tumor removed from the side of my right thigh. Nothing major. 2 days in the hospital. It was a huge gooma they took out of there, so it was a little bit of a procedure. So after discharge from the hospital, pain control, I was told by the nurse practitioner that pain control is important to keep the pain under control, because one of the most important things after surgery is to keep the person moving around so they don't develop blood clots. But upon discharge, I was discharged from the hospital for a prescription of 100, count 100, extra strength 10 milligram Percocets. So I think that's really basically a month's supply. Do you think that's really a right way to discharge somebody and manage their pain? Just give them a huge prescription of uh, highly effective narcotic medications and say, have at thee, have the best of luck to you. I mean, on the street, I could have made a fortune with this if I wanted to, but I didn't. Or I think a better way probably would have been to write a smaller prescription and say, let's see you in a week. Follow up in our clinic and let's see how you're doing. But what do I know? But also, you got to think that a big cause of opioid overdose is not just from big agencies, but some individual, pharmaceutical companies, but also individuals themselves. This is a doctor that I actually worked with when I worked in a hospital in Manhattan, Cabrini. He was intensivist, ICU, pulmonologist, brilliant physician, had his own practice in Gramercy Park. His name was Hector Castro. And about 4 or 5 years ago, he was actually busted by the feds for running what was called a pill mill, selling prescriptions for highly effective, highly toxic controlled substances for basically 100 something at a time. And at the same time, his own secretary was stealing prescription pads and selling prescriptions for OxyContins and oxycodones to drug dealing gangs, making a fortune out of it. Needless to say, he was monitored, and it was really surprising to me because this guy was. I have to say, I learned a lot about intensive care medicine from this guy, but it just goes to show you how prevalent it is out there, and a big disappointment to his community. Then you have cocaine. Cocaine is nothing new. It's whereas heroin, morphine, OxyContin, oxycodone are narcotics. They're meant to, they kind of depress everything, slow the breathing down, they slow the pain responses, they lower your blood pressure, they just kind of sedate everything. Cocaine is a stimulant. It races everything up. It increases your heartbeat, increases your blood pressure, increases your level of awareness, increases just about all the metabolic activity in your body. And once again, as like all these, induces a severe rush of euphoria, comparable to what some people say was the best orgasm of their lives. Where most cocaine comes from is the southwest areas, northwest areas of South America, and these mountains from the coca plant. Now, the coca plant is by itself is relatively benign. People in these lands who farm in these lands for centuries have chewed on coca plants for a little bit of energy boost. Nothing more than the same thing as taking our energy, which is kind of especially important living in these areas where the altitude is high and the air is thin. But somewhere along the line, somebody discovered that the fact that they could extract the active ingredient from these plants, mix it up with some other chemicals, and make that very potent substance, cocaine. And cocaine, again, had to be. You know what, Joyce Lee? How do people think of these things? The human population has been experimenting with mind-altering substances probably since the beginning of time. Most of the times, it's trial and error. Humans are curious by design. Small toddler will put anything in their mouths, regardless of what it looks like, and just over time figure out this looks kind of good, and then combine that with a degree in chemistry, and there you go. So cocaine again, was highly touted in the late 18th century, 19th century in the United States. It was put in all sorts of different patent medicines meaning medicines that really had no proven effect for anything. Anybody could sell them. It was, yeah, you probably major ingredient in Coca-Cola. Coca-Cola's campaign slogan was "Help relieve fatigue." Well, yeah, cocaine will do that to you, and it was really not touted on too much, and it was very, very popular in the party scene in the late 70s and the mid to late 70s, early 80s. It was a very big, prominent uh, effect in the party culture, in the Wall Street culture, and it seemed to be the drug of the elite, the well-to-do, the more well-off. And until the Reagan administration and Nancy Reagan really tried to push the Just Say No campaign, which might have had some effect at some point, until somebody else figured out how to build a better mousetrap and combine cocaine with cocaine is basically introduced into the body. It can be injected into the bloodstream, but most people know that's highly dangerous. Most people that inject cocaine die of cardiac arrest almost immediately. But otherwise, most people wind up sniffing it and letting it absorb through the mucous membrane, nasal passages, and slowly, moderately release into the bloodstream, until somebody realized that they could basically free up the most active part of cocaine chemical and put it in a mixture called crack, where it could be inhaled basically at its most purest form. And once the crack is inhaled, it's released from the alveoli into the bloodstream almost immediately, and the effects are just about immediate. And unfortunately, they don't last that long. And we talked about the effects of cocaine. We'll go past that. Now, the crack itself, crack epidemic in the early 80s itself, that's okay. You can, email me later if you need to. Now, we all talked about how heroin and IV drug use um, contributes to hepatitis C and AIDS through the distribution of dirty needles. Cocaine and crack generally is not introduced into the body through dirty syringes. It's through inhalation, yet it still led to a spike in the incidence of HIV and AIDS in the mid to late 80s. Anybody have an idea why that happened? Well, crack produces a very intense high. A vial of crack was really not expensive, but as I said before, the high from the crack doesn't last very long, about 10-15 minutes. So you need multiple hits to maintain that level of high, and then ultimately to avoid the withdrawal symptoms that we talked about. How do most people come upon that income to pay for their habit? Sex for drugs trade. So again, most people who have a crack addiction are not practicing safe sex. They're practicing with multiple partners and just to get whatever kind of scraps of money they can to enjoy that high. And if anybody's ever seen this movie, Maria Full of Grace, excellent movie that was on HBO for a short time, really accounts for how a lot of the substance gets into the country to begin with. You know, I don't want to get too political here, but all this talk about putting up a big wall on the Mexican-American border is going to stop all this trafficking. I mean, how many people are you going to stop walking through a multi-million-mile desert carrying drugs? And how's it stop airplanes? How's it going to stop the tunnels? And how's it going to stop people like this? The story accounts for a young teenage girl who lives in Colombia. You know, she works in a rose stripping factory. She supports her mother and her little brother and her sister, who also has a child. She has kind of a scumbag boyfriend who doesn't really give two bits about her. She doesn't really have much of a life, and she ends up becoming pregnant. And at a party, she meets some other guy, and who talks to her and introduces her to this way of life of, you know, bringing in a lot of extra cash. So he rides with her into the city and meets with an agent of one of the local drug cartels who offers her a job and throws down a wad of cash in front of her to hire as what's called a mule. A mule is a slang term for someone who will ingest these little rubber sacks, condoms really, of cocaine. They put them in their body, they're called body packers, and they'll swallow about 20 to 30 little packets of cocaine, get on an airplane, travel across the border with these packets of cocaine in their bodies, and then they'll meet up with some on the other side of the destination, spend time in the trap house until they're ready to pass it all out the other end. Messy job. And if she takes in 20 bags and 20 bags are not accounted for by the time she gets to her destination, the cartel will wipe out her whole family. So there's a big monetary incentive to do this job, but there's also a big threat of having her whole family wiped out if she doesn't do the job to design. So, and you know, a lot of this was discovered back in '89 when a plane from Colombia crashed. Then never made it to Kennedy Airport. There was technical failures, and the plane actually ran out of fuel, and it crashed out onto the Glen Cove area of Long Island. And because they had found is several days later, I mean, there were a lot of fatalities, but they also people that survived in the hospital were passing these bags of cocaine. It was like, oh, that's how we really discovered that, and it's been a problem. It's been going on ever since. Yeah, she was. That's interesting. So she was pregnant, and one of the ways they detain the mules, so to speak, at the airport is customs officials will detain people they think look suspicious, and they'll bring them and they'll have them X-rayed, and they can usually find these little bags in their intestines on the X-ray. Because she was pregnant, and because she tested positive on the pregnancy test, they couldn't X-ray her. So I was able to see through and avoid that. So that was kind of a interesting subplot to the movie by design. If one of those little packs had popped in her intestines, she would have been dead right on the spot. So now, I'm kind of rambling on a little bit here, so we're just going to tie it up a little bit. Been some, because now back in the late 80s, we kind of knew that heroin and cocaine and all this other stuff was pretty bad, and nobody was going to really argue at this point. But in the 90s, now you had these called designer drugs that came into being. These so-called synthetic party drugs, club drugs, so to speak. This is where crystal meth made a big hit. If anybody's seen the show Breaking Bad, you've probably seen the whole storyline about the production and distribution of crystal meth. Crystal meth is a stimulant somewhat similar to cocaine, a lot more potent, big money in it, and highly addictive. It's not so difficult, really, to break a cocaine habit. To break a crystal meth habit is almost, I say, almost impossible. And the effect it has on somebody is really very well documented in these two previous slides here. This is all the same person over 10 years of crystal meth use. And the toxic chemicals that crystal meth is mixed with really is kind of a dental and an oral surgeon's wet dream to work with, although most of the people on crystal meth don't have really good dental plans. But the problem with crystal meth is some of it is imported from other countries, but a lot of it is homegrown in what's called clandestine laboratories using a lot of volatile chemicals and highly toxic chemicals. And this could be right next door to somebody's neighborhood in their garage, and any one of these chemicals goes off, the whole laboratory can explode and turn it into a whole hazmat situation that can basically contaminate the whole block or even half the whole neighborhood. And interestingly enough, one of the main ingredients traditionally that was used in this chemical was a very common over-the-counter product called Sudafed. Now, Sudafed is not an illegal drug. It's not even a controlled substance, But to buy Sudafed now, true Sudafed, you have to actually show your ID and sign a log when you go to the pharmacy to keep it behind the counter, because DEA agents have seen what it's like for people that were going store to store and buying tons of Sudafed to make that drug. Now, obviously, they learned to use other agents, so that's still in existence. And as I said before, once these labs are discovered and busted, they are automatically hazmat scenes as well as crime scenes that need to be taken down and decontaminated, which is a very, very long process. And in the club scene, the rape scene, ecstasy, MDA is very popular. It's still popular. It's a combination stimulant versus hallucinogen. It has a lot of different properties. One of the reasons why it's so popular in the club scene is because it has stimulant properties that allow down the periods of time. It has sedative properties that allows one to feel comfortable among strangers, relaxed, more at ease, more social. It has hallucinogenic properties in that it can it tends to lend itself to seeing like these little strobe lights in your eyes. If you had a glow stick in the dark and you were waving it around and I took a picture of it, you'd see the whole trail of that glow stick as it was captured in time. That's kind of an effect ecstasy has. It has weird hallucinogenic visual effects that people seem to. That part is GA, gamma hydroxybutyrate. You see a lot. You see, it seems to be very real in the actual community. It's been for a long time. It's only been legal for the last 20 years, but it's sedative. It's a sedative type of drug, not unlike Valium. Am I picking up? Not like Valium. Really, person. And does anyone know what a big GAB is? Is anybody not understanding what I'm saying? How's my sound now? Okay, having mic problems. Okay, can you guys hear me now? That's my dumb computer. So GHB is very commonly known as a date rape drug. It's not uncommon for somebody in the party in the club to not look after their drink for a second and have this colorless, odorless substance slipped into their drink, and before they even know it, wake up in an alley or a parking lot having been sexually assaulted. Let's go into the details of that. The bottom line is watch your drink. And now what's become pretty popular lately is these synthetic canthinones called bath salts. Bath salts are not the things you get from Bed Bath & Beyond. They're not stuff you put in a hot tub in a bubble bath. There are all sorts of products that are in packages and potpourri and all sorts of interesting concoctions, and they have a very, very high stimulant and hallucinogenic effect to the point where they can cause madness and delirium. It's hard to control the sales of these things because they're packaged in a way that they're labeled, quote, not fit for human consumption, unquote, but people that know about these products tend to know better. They know that they cause an intense high. I don't know if you remember a situation that happened in Florida. Exactly. Well, no, actually, we'll talk about something else that caused people into zombies. But yeah, yes, that too, actually. There was an incident that happened in Florida with someone who was so high on bath salts, approached a homeless individual on their bridge and basically tried eating his face off. And then you have, yeah. And then you have synthetic marijuana, which is really not like your traditional marijuana in any way, shape, or form at all. It's chemically made. It's not natural. Common names for it are spice or special K. And there's a whole array of products that can give you a similar high to marijuana, but they can also give you other effects as well. And one of the reasons why it's so hard to keep these products out of control, you see packaged as incest or herbal smoke blends, and problem is the DEA catches some of these, they analyze it, they ban it, but you just add one little different chemical additive to it, and it's a whole different product, and they got to go through the whole situation all over again. And yes, this is usually what you see in the newspaper when you see areas of Brooklyn and the Bronx, huge outbreaks of people who are exhibiting, like you said, the zombie-like behavior and massive amounts of drug-induced highs, usually from one from one source. Most of the time, these things give an uneventful high, but every now and then you get basically these outbreaks that are very difficult to control and very taxing on the EMS system, very taxing on the emergency department system. And in this day and age, it can be even a bigger problem for the public health system. So in any event, I'm going to finish up with putting this slide up here, resources for treatment. There's a bunch of different resources for treatment. Use of Mental Health Service Administration, SAMHSA is a good one, Center for Disease Control. So I'm going to close it up with there. If you have any questions, I'll be online for a couple more minutes. As far as next week goes, we're going to be talking about environmental emergencies, hot and cold emergencies, bites and stings. There'll be a quiz on. Oh, Olga, go ahead. The tuberculosis vaccine, it's not even given in this country, it's given in other countries, because it's actually just any vaccine, it can dwindle over time. That's why with a lot of vaccines like measles, mumps, rubella vaccine, tetanus, diphtheria vaccine, they want to get boosters. The BCG vaccine was never very effective to begin with. That's why when you've had it in another country and you come to this country and you're applying for a job that requires it, a lot of times they still want to require you to have a tuberculosis test. Now, if you had the BCG vaccine and you wind up getting the tuberculin skin test, you'll test positive. But lately, there's been a new test called a beta quantiferin, which is a blood test that can tell if you've been exposed to tuberculosis or not. Okay, if that's it, then I wish you all have a very wonderful Thanksgiving. Please be safe. Please be careful. And I will see you guys well, yeah, I will. And Getty, you can answer your own question. What do you think? Nothing too hard, though, I promise you. Have a good one, everybody. The quizzes have always been located in the lesson tabs on the left side of Blackboard. Period. I have mentioned that in class several times. Period. I find it odd that 20 students know where to find the quiz and you don't. I will waive today's grade, but you still have 2 more quizzes, 2 more homeworks, and the final exam. At the beginning of the semester, I offered to have a live with you one-on-one to go over how to access everything on the panel, and you never responded to that, period.